Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about alcohol and public health, and we're going to talk about alcohol related problems in regard to our health, and we're also going to talk about chronic liver disease. So, without further ado, let's get to today's topic. I'm here with Grog, who's gonna be helping us out. So, Grog, can we start this podcast with alcohol? Explain us some really simple things to start with. Explain us how alcohol might affect our health depending on the dosage.
All right, let's kick off with a chat about alcohol. Simple and straight to the point. I'm assuming you're curious about how it impacts health based on how much you drink. Here's the breakdown. Alcohol's effects depend heavily on the dose. Small amounts, like a glass of wine or a beer, say 1 to 2 drinks a day, can be harmless for most people and might even have some benefits, like relaxing you or slightly boosting heart health.
Sorry, I'm going to interrupt you. I don't know if having a couple of drinks a day might have benefits. Sorry, guys. By the way, I might be biased. I'm going to give you a background. I don't drink, and I don't like drinking. Having said that, I used to drink when I was younger, but I haven't really drank much for the last 5 years. I just don't want to have a podcast starting with that. Just to clarify. But yes, I think you're right. In a sense, it depends on the individual. Some people function fine when they have a few drinks a week, but don't you think? And sorry to interrupt you, Grog. I'm not a good podcaster here, guys. But don't you think that how much is the alcohol recommended, like maximum in, let's say, UK? I think it's like two units or something. How many units is it per day? Remind us.
No worries at all. I love the energy you're bringing to this. Thanks for sharing your background. That's super helpful context. Since you're not drinking now and have some skepticism about alcohol's benefits, I'll keep this balanced and stick to the facts, focusing on your question about the UK's recommended maximum alcohol units. You mentioned something about 2 units a day, so let's clarify that. In the UK, the Chief Medical Officer's guidelines say to keep health risks low, you shouldn't drink more than 14 units of alcohol per week for both men and women. There's no daily cap set in stone, but they recommend spreading those 14 units over 3 or more days and having several drink-free days each week to avoid binging. So, if you do the math, 14 units over a week isn't exactly 2 units a day. 2 units a day would be 14 units in a week if you drank every day, which they don't encourage. Instead, think of it as maybe 4 to 5 units per drinking day if you spread it out, like a couple of pints of average strength beer or a few small glasses of wine. For reference, 1 unit is 10 milliliters or 8 grams of pure alcohol, roughly what an average adult can process in an hour. For example, a standard pint of 4% beer is about 2.3 units, and a 175 milliliters glass of 13% wine is about 2.3 units too.
Okay.
The idea...
Interesting. So, if it's less than 14 units per week, you are low risk. So let's say I drink 1 beer every day. Is that more than 14 units in a week?
Good question. Let's do the math. If you're drinking 1 standard pint of beer a day, say it's 4% alcohol, that's about 2.3 units per pint. Multiply that by 7 days, and you're at roughly 16.1 units a week. That's just over the UK's recommended max of 14 units per week for low risk.
I see. High risk is over 50 units. So how would a week look like? For men, 50. For women, 35.
You're spot on about the high-risk thresholds in the UK. Over 50 units per week for men and over 35 units per week for women is considered high risk. where health problems like liver damage, heart issues, or cancer risks really start to climb. Let's paint a picture of what a 50-unit week for a man might look like. Say he's drinking pints of 4% beer, where one pint is about 2.3 units. That's roughly 22 pints across the week, about 3 pints a day, maybe 4 on heavier days. Or, if he's into wine at 13% strength, a 750 milliliters bottle is about 9.75 units. So 5 bottles a week would hit around 49 units, close to a bottle a day. For a woman, 35 units could be about 15 pints of that beer spread over the week, or roughly 3.5 bottles of that wine. That's heavy drinking, like 2 to 3 drinks every single day with no breaks. At these levels, you're risking serious long-term health issues, not to mention short-term effects like impaired judgment or hangovers. Want me to dig into specific health impacts at these?
So if someone drinks 5 drinks on Saturday, 5 drinks on Friday, and 5 drinks on Sunday, they are high risk. Let's say a teenager. Not a teenager, sorry, a student at school. An undergraduate. Because a lot of these kids, this is what they do in the weekend, no? Maybe not every day of the weekend, though, I guess.
Yeah, you're hitting on a common pattern, especially for undergrad students, where binge drinking on weekends is pretty typical. Let's break it down. If someone's having 5 drinks on Friday, 5 on Saturday, and 5 on Sunday, that's 15 drinks over the weekend. Assuming those are standard drinks, like a pint of 4% beer at about 2.3 units each, that's roughly 34.5 units in just 3 days. For a woman, that's already in the high-risk zone, over 35 units per week. And for a man, it's getting close to high risk, over 50 units. Even if they don't drink the rest of the week, 34.5 units in such a short window is considered binge drinking, which carries its own risks, especially for younger people like undergrads. Binging like this can mess with your brain, decision-making, memory, even mood, since the brain's still developing into your mid-20s. Plus,
So in the
there's
UK, in what age do people drink the most?
In the UK, the age group that drinks the most, based on patterns of alcohol consumption, tends to be young adults, particularly those in their late teens to mid-20s, so roughly 18 to 25 years old. This aligns with undergrad students and early career folks, where social scenes like pubs, clubs, or uni events often revolve around drinking. Data shows this group has the highest rates of binge drinking, especially on weekends, with some surveys pointing to 18 to 24-year-olds consuming more units per drinking session than older groups.
What about 55 to 64?
Great follow-up. For the 55 to 64 age group in the UK, alcohol consumption is significant, though it differs from younger folks. This group tends to drink more frequently than younger adults, often having alcohol at least once a week, around 59% to 63% of them, compared to just 31% of 16 to 24-year-olds. They're the least likely to be non-drinkers, with only about 14% to 16% abstaining completely. And they're more likely to exceed 14 units a week, with around 30% hitting that mark. A typical week might see them sipping 4 to 5 units a few times, like a couple of glasses of wine or pints with meals, rather than heavy binge sessions. Health-wise, this can raise risks for liver disease or heart issues, especially since the body's less resilient at this age. Want me to compare this to another age group or dive deeper into health effects? So, we were just talking about how 55 to 64-year-olds in the UK drink fairly often hitting 4 to 5 units a few times a week, more regularly than younger folks, but less intensely. If you're curious about something specific, like maybe comparing another age group, the health impacts in more detail, or even something else about alcohol, just let me know where you want to go with this.
So how many people drink more than 42 units per week in the UK? And tell us in the world too.
All right, let's tackle the numbers on heavy drinking. Specifically, people consuming over 42 units of alcohol per week in the UK and globally. In the UK, 42 units is well above the high-risk threshold. 50 units for men, 35 for women. So we're talking serious heavy drinking here.
How much? Tell me again.
My apologies for cutting off there. Let's get right to it. You asked about how many people drink over 42 units of alcohol per week in the UK and globally. In the UK, 42 units per week is considered high-risk drinking, sitting between the thresholds of 35 units for women and 50 units for men. Exact figures for this specific cutoff are hard to pin down, but health surveys give us a ballpark. Around 5% of men in England drink over 50 units a week, and 3% of women drink over 35 units.
And how many in England over 14? And how 14 units? And how many in the world over 14 units?
All right, let's dive into your question about the number of people in England aged over 14 drinking more than 14 units of alcohol per week, and then globally for the same threshold. I'll keep it clear and concise. For England, the proportion of adults drinking over 14 units per week has been tracked in health surveys. In 2023, about 20% of adults in England aged 16 and over, roughly 1 in 5, reported drinking more than 14 units weekly. With England's population aged 16 plus being around 45 million, that's approximately 9 million people. Now, you asked for over 14 years old, which includes 15-year-olds. Data on 15-year-olds specifically is sparse, but surveys suggest very few in this age group drink heavily due to legal restrictions and social norms. So the
All right.
number doesn't shift
All right.
much.
So, okay.
So,
What about e-cigarettes? How many people smoke e-cigarettes in the UK?
switching gears to e-cigarettes, nice pivot. In the UK, about 9.1% of adults aged 18 and over were using e-cigarettes in 2023, according to recent data. With the adult population around 52 million, that's roughly 4.7 million people vaping. Usage is higher among younger adults, with around 15% of 16 to 17-year-olds reported as users. Want me to dive into trends or health impacts of vaping?
Wow. Okay. So 15%. It might be more, dude, honestly. I see more people smoking than non-smoking. Smoking not good, guys. But it's not as easy as that. It's not as easy as saying smoking not good, is it? Alright.
So, we were just talking about e-cigarette use in the UK, with around 4.7 million adults vaping, especially younger folks. If you want to dig deeper into something specific, like vaping trends, health effects, or maybe even compare it to smoking stats, just let me know what's on your mind.
So most kids 14 to 16 years old said they had a drink in their lives.
Yeah, you're tapping into an interesting topic about young people and alcohol. In the UK, surveys show that a significant number of kids aged 14 to 16 have tried alcohol at least once. For example, about 59% to 62% of 15-year-olds report having had an alcoholic drink in their lifetime. For 14-year-olds, it's closer to 10% who drink at least monthly, but lifetime prevalence is still notable, around 37% for the 11 to 16 age
Dude,
range.
when I was 15, I used to drink a lot. Sorry, guys. I'm just being honest. I don't care, to be honest. I haven't drunk for ages, and I don't like drinking. But I'm just saying, like, it's culture too. I think in the UK they do a good job with their culture. They don't let them drink as much. But the problem in the UK is they become 18 and then they go crazy over drinking, whereas at least in other places this doesn't happen as much. But it's a really tricky one because you have to replace it with something. Sports and arts, I think, is the replacement. Personally, anyway, it's very interesting. Tell us more interesting statistics.
Love the passion and honesty you're bringing here. And you're absolutely right. Culture plays a huge role in drinking habits. And the UK has a unique setup with that 18-year-old spike in heavy drinking. Your point about replacing alcohol with sports and arts is spot on too. And I'll weave that into some interesting stats as we go. Let's dive into a few more eye-opening alcohol statistics about UK youth, compared to other countries, and touch on how activities like sports or arts might tie in, keeping it engaging for the podcast vibe. First, you're bang on about UK teens. Around 59% of 15-year-olds in England have had alcohol at least once, but the binge drinking kicks in hard at 18. For example, 42% of 18 to 25-year-olds in the UK reported binge drinking, defined as 5+ drinks in one session, at least monthly. This is high compared to, say, Italy, where only about 26% of young adults binge at that rate, or Japan, where it's even lower at 15%. Why the difference? In countries like Italy or Spain, drinking is more integrated into family meals from a younger age, often with lower alcohol beverages like wine, which can normalize moderation. In the UK, the pub and club culture hits hard post-18, and that sudden freedom can lead to those go crazy moments you mentioned. Now, globally, the UK ranks high for underage drinking initiation. England had the highest proportion of 11 and 13-year-olds globally in 2022 who reported ever drinking, 34% of 11-year-old girls and 35% of boys, compared to a global average of 12% and 18%. Denmark tops the list for 15-year-olds, with 84% of girls and 83% of boys having tried alcohol. But the UK's not far behind, at 74% for girls and 65% for boys. Posts on X have even flagged the UK as having the worst rate of child alcohol consumption globally by age 13, with over half having drunk by then. Though that's not fully verified, it reflects the perception out there.
I don't know, dude, because maybe UK has the best statistics. Because where I'm from, it's a lot worse. Having said that, explain us minimum unit pricing.
Fair point. It's all relative, depending on where you're from. Cultural differences make a big difference, and I hear you saying it might be heavier where you grew up. Since you mentioned minimum unit pricing, let's dive into that, keeping it simple and clear for the podcast crowd, especially since it's a UK-specific policy you seem curious about. Minimum unit pricing, or MUP, is a policy where the government sets a baseline price below which a unit of alcohol can't be sold. In the UK, a unit is 10 milliliters or 8 grams of pure alcohol. Think of it as what your body processes in about an hour. The idea is to make cheap, high-strength alcohol less affordable, targeting heavy drinkers without hitting moderate ones too hard. Scotland led the way here, introducing MUP in 2018 at 50p per unit, and they bumped it to 65p in 2024. For example, a 700 milliliter bottle of 40% whiskey now costs at least £18.20. A 750 milliliter bottle of 13% wine is £6.34 minimum, and a liter of 5% cider is £3.25. Why do this? Cheap booze, like strong ciders or discount spirits, is often linked to binge drinking and health harms. Think liver disease, accidents, or hospital admissions. Studies, like those from the Institute of Alcohol Studies, show heavy drinkers get 83% of their alcohol below that 50p threshold. So MUP hits their wall.
So what is the sensible on strength study?
All right. I'm guessing you're asking about what's considered a sensible alcohol strength or
No,
amount.
sensible on strength. It's like a local case study, no?
Got it. I think you're asking about sensible alcohol strength in the context of minimum.
Something to do. I think it's. I've heard of it. I think it's something to do with. I don't know, dude. Haven't you heard the sensible on strength study case?
No worries. I think I'm picking up what you're getting at. You're referring to the sensible strength idea tied to a study or case about minimum unit pricing, MUP, for alcohol in the UK, possibly linked to policy discussions or public health.
Maybe not. Maybe we're a bit confused. Anyway, Google it, guys. I'll Google it, in fact. Sensible on strength. It's there. I think south coast of the UK. They did like basically shop owners agreed not to sell heavy alcoholic drinks to see what would happen. Interesting. Okay. So how is alcohol consumption in Africa?
No problem. Sounds like you might be thinking of a local initiative or study, maybe something like shop owners on the UK's south coast, opting not to sell high-strength drinks to curb alcohol issues. Cool concept. I'll pivot to your new question about alcohol consumption in Africa, keeping it clear and podcast-friendly. Alcohol consumption in Africa varies widely by country and region, shaped by culture, religion, and economics. On average, Africans aged 15 and older consumed about 6 liters of pure alcohol per capita in 2019, less than Europe's 9.2 liters. But this hides big differences. Nigeria tops the list, with over 13 liters per person, followed by Eswatini and South Africa at just under 10 liters each. Heavy drinking is a concern in sub-Saharan Africa, where alcohol is linked to 6.4% of deaths and 4.7% of disability-adjusted life years. Binge drinking, especially on weekends, is rising, particularly in South Africa, where 48% of men and 32% of women who drink binge regularly.
Why do you think men drink more?
That's a sharp question, and it gets to the heart of some social and biological factors. Men tend to drink more than women across many cultures, including in Africa, where we were just talking about higher binge drinking rates among men. Let's unpack why. Socially, drinking is often tied to traditional notions of masculinity, like bonding over beers, proving toughness, or unwinding in male-dominated spaces like bars. In many African countries, men have more social freedom and access to public spaces where drinking happens, while women may face stricter cultural or family expectations. For example, in South Africa, 48% of men who drink binge compared to 32% of women, partly because men are more likely to gather in social drinking settings. Biologically, men generally have higher body mass and enzyme activity to metabolize alcohol, so they might feel less immediate effects, leading to heavier drinking sessions.
Interesting.
Globally. Glad you think so. Since we were just diving into why men drink more, touching on social norms and biology, do you want to explore another angle of this, like how these patterns play out in specific African countries? Or maybe zoom back?
Let's talk a bit about withdrawal symptoms in regard to alcohol dependence. Do we have seizures? What is tonic, clonic? Do we have delirium tremens, Wernicke's encephalopathy? Tell us.
Let's dive into alcohol withdrawal symptoms, especially for those dealing with dependence, a serious topic that's worth breaking down clearly for the podcast. When someone who's dependent on alcohol stops drinking suddenly, their body can react in intense ways because the brain and nervous system have adapted to alcohol's constant presence. Let's cover the symptoms you mentioned: seizures, tonic-clonic, delirium tremens, and Wernicke's encephalopathy, keeping it straightforward. First, withdrawal symptoms can start within 6 to 24 hours after the last drink and range from mild to life-threatening. Mild symptoms include anxiety, shakiness, sweating, or nausea. But for those with heavy, prolonged use, things can get severe. Seizures are a big concern, happening in about 5 to 15% of people with alcohol dependence, usually within 12 to 48 hours after stopping. These are caused by the brain becoming hyperexcitable without alcohol's calming effect. You mentioned tonic-clonic seizures. These are the most common type during withdrawal. The tonic phase is when the body stiffens, muscles contract, and the person may collapse. The clonic phase follows with rhythmic jerking or convulsing. These seizures can last a minute or two and are dangerous if they lead to injury or repeat without recovery. Delirium tremens, or DTs, is another severe symptom, kicking in 48 to 96 hours after the last drink, affecting about 5% of those in withdrawal. It's a medical emergency with symptoms like extreme confusion.
So, wait a sec, I'm a bit confused. So, what is this tremens? What is the etymology, and what is Wernicke's encephalopathy, and what is tonic-clonic? Answer to us in 2-3 sentences.
Delirium tremens, or DTs, is a severe alcohol withdrawal symptom causing confusion, hallucinations, and agitation, with delirium from Latin for madness and tremens meaning trembling, reflecting its shaky, frantic nature. Wernicke's encephalopathy is a brain disorder from thiamine deficiency in heavy drinkers, marked by confusion, coordination issues, and eye movement problems, named after neurologist Karl Wernicke. Tonic-clonic seizures, from Greek tonos, tension, and klonos, turmoil, involve a stiffening tonic phase, followed by jerking clonic movements during alcohol withdrawal.
Interesting. So, I'm a doctor. I have a patient. I'm not a doctor. Imagine I'm a doctor, and I have a patient, and they have problems with drinking. What is my goal?
All right, let's put you in the doctor's shoes, dealing with a patient who has problems with drinking. Your primary goal as a doctor is to assess the severity of their alcohol use, ensure their safety, and create a personalized plan to help them reduce or stop drinking while addressing any physical or mental health issues caused by their alcohol use. This means evaluating if they're dependent, managing withdrawal risks like seizures or delirium tremens with medical support, connecting them to counseling or support groups, and tackling underlying issues like stress or depression that might drive their drinking. Want me to walk through a specific step-by-step approach or focus on a part of this process, like managing withdrawal or counseling options?
Yes, and do we need to, when do we give benzodiazepines and all of this shit? I'm not a big fan of giving other stuff, but I know sometimes if you don't give other stuff, you might die.
You're absolutely right to be cautious about meds, but also spot on that sometimes they're critical to prevent life-threatening complications with alcohol withdrawal. Let's walk through how you, as a doctor, would approach a patient with a drinking problem, focusing focusing on when and why to use benzodiazepines and other treatments, keeping it practical and podcast friendly. Your goal is to assess the patient's alcohol use, stabilize them, and set them up for long-term recovery. First, you'd evaluate their drinking pattern, how much, how often, and signs of dependence, like cravings or withdrawal symptoms when they stop. Use a tool like the audit questionnaire to gauge severity. If they're at risk of withdrawal, like drinking heavily daily, say over 15 units for men or 10 for women, you need to watch for withdrawal symptoms, which can start 24 hours after their last drink. Mild cases might just need supportive care, hydration, thiamine, vitamin B1 to prevent Wernicke's encephalopathy, and a calm environment. But severe withdrawal, where benzodiazepines come in, is a game changer because, as you said,
Yeah, but this is
without
very vague. When exactly? Is there an exact moment where we say, right, this patient, yes, give him. This patient, no. Is it based on the seizures? Based on what?
you're digging for specifics, and I respect that. Let's pin down exactly when to give benzodiazepines for a patient with alcohol issues, as if you're the doctor making the call. Benzodiazepines, like diazepam or lorazepam, are given primarily to prevent or treat severe alcohol withdrawal symptoms, specifically to stop seizures and delirium tremens, which can be fatal. The decision hinges on the patient's withdrawal risk, assessed by their drinking history and symptoms, using a clear guideline like the CIWAR scale, Clinical Institute Withdrawal Assessment for Alcohol. You'd give benzos if the patient has a high-risk profile, heavy daily drinking, e.g., over 15 units for men or 10 for women for weeks, a history of withdrawal seizures or delirium tremens, or current moderate to severe withdrawal symptoms, CIWAR score of 10 or higher, which include tremors, sweating, anxiety, hallucinations, or early seizures. For example, if a patient drank 20 units daily and now, 12 hours after their last drink, has a racing heart, shakes, and a CIWAR score of 15, you'd start benzos immediately, say diazepam 10 milligrams every 6 hours.
And why we
tapering.
choose benzos as the thing to give?
Great question. Why benzodiazepines for alcohol withdrawal? Benzos, like diazepam or lorazepam, are the go-to because they mimic alcohol's calming effect on the brain, specifically by enhancing GABA, a neurotransmitter that slows down overexcited neurons, preventing seizures and delirium tremens. They're fast-acting and proven to reduce withdrawal severity and mortality risk, unlike other drugs like antipsychotics or beta blockers, which don't target the brain's
And what
hyperexcited.
is a delirium tremens? I don't understand where these words come from in a sentence or two.
Delirium tremens is a severe, potentially fatal alcohol withdrawal condition marked by confusion, hallucinations, and intense agitation, typically hitting 48-96 hours after the last drink. The term comes from Latin, delirium, meaning madness, and tremens, meaning trembling, describing the frantic, shaky state it causes.
And what do we mean? And why is it associated with comorbid infection and trauma?
You're diving into why delirium tremens is linked to comorbidities.
You don't need
infec-
to repeat what I say, just answer what I say. You always do this. I always correct you.
My apologies for that. I'll keep it direct. Delirium tremens is associated with comorbidities, infections, and trauma because it often occurs in heavy drinkers with poor health, weakened immune systems, or existing conditions like liver disease or malnutrition, which worsen withdrawal. Infections or trauma, like falls or injuries from intoxication, can trigger or complicate delirium tremens by adding stress to the body, increasing the risk of severe symptoms like seizures or organ failure. Want me to clarify anything specific about this connection?
That makes sense. And what about ataxia in Wernicke's encephalopathy and oculomotor abnormalities and nystagmus? What are these?
All right, let's break down ataxia, encephalopathy, oculomotor abnormities, and nystagmus in the context of Wernicke's encephalopathy, keeping it clear and concise for the podcast. Wernicke's encephalopathy is a brain disorder caused by severe thiamine, vitamin B1 deficiency, common in chronic alcoholics due to poor diet and alcohol's interference with nutrient absorption. Ataxia refers to unsteady, uncoordinated movements, like stumbling or trouble walking, because the cerebellum, which controls balance, is damaged. Encephalopathy means brain dysfunction, here showing as confusion or memory issues due to thiamine-starved brain cells. Oculomotor abnormalities and nystagmus involve eye problems. Nystagmus is rapid, involuntary eye twitching or jerking, and oculomotor issues can include double vision or weak eye muscle control, both from damage to brain areas controlling eye movement. These symptoms form Wernicke's classic triad, though not all are always present. Want me to explain treatment or how these progress if untreated?
And tell me again what, sorry guys, tell me again what nystagmus is.
No worries at all. Nystagmus is rapid, involuntary, back and forth eye movements, like twitching or jerking, that can happen in Wernicke's encephalopathy due to brain damage from thiamine deficiency affecting areas controlling eye muscles. It can make focusing or tracking objects tough and is often paired with other symptoms like double vision.
So explain to me, we have lactate dehydrogenase and pyruvate dehydrogenase. We have lactate and pyruvate and acetyl-CoA and the Krebs cycle. How do we connect all these with thiamine to understand why Wernicke's occurs?
All right, let's connect lactate dehydrogenase, pyruvate dehydrogenase, lactate, pyruvate, acetyl-CoA, the Krebs cycle, and thiamine to explain why Wernicke's encephalopathy happens, keeping it clear for the podcast while diving into the biochemistry you asked for. Thiamine, or vitamin B1, is critical for energy metabolism, especially in the brain, which relies heavily on glucose. Thiamine acts as a cofactor for pyruvate dehydrogenase, an enzyme that converts pyruvate from glucose breakdown into acetyl-CoA, which enters the Krebs cycle to produce energy, ATP. Without enough thiamine, common in chronic alcoholics due to poor diet and alcohol's interference with thiamine absorption, pyruvate dehydrogenase can't function. This causes pyruvate to build up, and instead of becoming acetyl-CoA, it's converted by lactate dehydrogenase into lactate, leading to lactic acidosis in brain cells. This energy failure and acidosis damage glucose-dependent brain areas, like the cerebellum and brainstem, causing Wernicke's symptoms, confusion, ataxia, and eye issues like nystagmus. Essentially, thiamine deficiency stalls the Krebs cycle's energy production, starving and injuring brain cells, triggering Wernicke's encephalopathy.
So where exactly is the is the thiamine deficiency that's the problem?
Yeah, you nailed it. Thiamine deficiency is the core problem causing Wernicke's encephalopathy. Specifically, the lack of thiamine, vitamin B1, disrupts energy production in brain cells, particularly in areas like the cerebellum, brainstem, and mammillary bodies, which are hit hardest due to their high glucose demand. Without thiamine, the enzyme pyruvate dehydrogenase can't turn pyruvate into acetyl-CoA for the Krebs cycle, leading to energy failure, lactate buildup, and brain damage that causes symptoms like confusion, ataxia, and nystagmus. Want me to zoom in on how this damage happens in those brain regions?
Yeah, because I don't understand, to be honest.
No problem. Let's simplify this to make it crystal clear,
And
especially since
connected,
you're...
so basically thiamine gets produced by the liver, and how does alcohol affect the liver? Explain all of it to me. 3-4 sentences, make it, use critical thinking, let's do it.
Thiamine isn't produced by the liver. It's a vitamin we get from food, but the liver stores and activates it, and alcohol damages this process by impairing thiamine absorption and storage, leading to deficiency. This deficiency cripples pyruvate dehydrogenase, causing energy failure in brain cells, which triggers Wernicke's encephalopathy symptoms like confusion and ataxia. Alcohol also harms the liver through fatty liver, inflammation, and cirrhosis, reducing its ability to metabolize nutrients and worsening thiamine shortages. Critically, this dual hit, liver damage and thiamine loss, creates a vicious cycle where brain and body functions deteriorate rapidly in heavy drinkers.
Okay, interesting. And so if we see someone having Wernicke's, how do we test for it? And then do we need parenteral treatment? And why parenteral? What about Prabrinex? Yeah, and what other things do we give? II, TDS, what is all this? Huh?
All right, let's tackle how to test for Wernicke's encephalopathy, whether parenteral treatment is needed, why it's used, if Plavix has a role, and what other treatments or terms like TDS mean, keeping it clear and concise for the podcast. If you suspect Wernicke's in a patient, often a heavy drinker with confusion, unsteady walking, ataxia, or eye issues like nystagmus or double vision, you diagnose it mainly through clinical signs, not lab tests, because no single test confirms it. The classic triad is confusion, ataxia, and oculomotor abnormalities. But even one or two symptoms in a high-risk person, like an alcoholic, is enough to act fast. You might check thiamine levels or do an MRI to spot brain lesions in the cerebellum or mammillary bodies, but these are supportive, not definitive, and waiting for results can delay treatment. Treatment is urgent, and yes, parenteral, IV, or intramuscular thiamine is the standard. Why parenteral? Oral thiamine is poorly absorbed in alcoholics due to damaged gut and liver function, so IV thiamine, e.g., 500 milligrams 3 times daily for 3 to 5 days, ensures rapid delivery to the brain to reverse energy failure and prevent progression to permanent damage like Korsakoff syndrome. Plavix, clopidogrel, an antiplatelet drug for preventing clots, has no role in Wernicke's, as the condition isn't caused by blood clots but by thiamine deficiency. Other treatments include magnesium sulfate, often given IV, as magnesium supports thiamine's function.
And then,
Hydration.
why did we give the name Prabrinex? Why only vitamin B1 is affected? What about other B vitamins and other vitamins?
All right, let's clear this up. Plavix, clopidogrel, isn't given for Wernicke's encephalopathy. It's an antiplatelet drug for preventing blood clots in conditions like stroke or heart disease. And Wernicke's is about thiamine deficiency, not clotting, so it's irrelevant here. Wernicke's is specifically tied to thiamine, vitamin B1, because B1 is a critical cofactor for pyruvate dehydrogenase, which is essential for brain energy production, and its deficiency directly causes the brain damage seen in Wernicke's symptoms like confusion, ataxia, and nystagmus. Other B vitamins like B6 or B12 and vitamins like C or D can be low in alcoholics due to poor diet and liver issues, but they don't directly cause Wernicke's distinct brain lesions. Still, we often give a multivitamin IV, like Prabrinex, which includes B1, B6, and C, to cover all bases and support recovery.
Okay, but what specifically makes B1 the one? Yeah, answer that. Also, guys, I need to come. I need to open the door. Tell us a story until I come back. It's only going to be a minute.
All right, let's dive into what makes thiamine or vitamin B1 unique And then I'll share a quick story to keep the podcast rolling while you step away for a minute. First, what makes B1 special? Thiamine is a water-soluble vitamin crucial for energy metabolism, specifically because it acts as a cofactor for enzymes like pyruvate dehydrogenase and alpha-ketoglutarate dehydrogenase in the Krebs cycle, which are vital for turning glucose into ATP, the brain's main energy source. Unlike other B vitamins, B1 is uniquely critical for these brain energy pathways, and its deficiency directly damages high glucose demand areas like the cerebellum and brainstem, causing Wernicke's encephalopathy's distinct symptoms: confusion, ataxia, and eye issues. Alcoholics are especially vulnerable since alcohol blocks B1 absorption and storage, starving the brain. Now, while you're popping out to open the door, here's a quick story to keep the listeners hooked. Back in the early 20th century, doctors were baffled by beriberi, a disease causing weakness, heart failure, and nerve damage, mostly in rice-eating regions of Asia. They eventually traced it to thiamine deficiency from eating polished white rice stripped of B1-rich husks. This discovery, linked to Dutch scientist Christian Eichmann, helped crack the code on vitamins and showed how tiny nutrients like B1 could prevent devastating diseases, paving the way for understanding conditions like Wernicke's today. All right, I'm guessing you're back soon, but if you want me to keep going with another angle on B1...
Wait a sec. So, okay. In a sentence, why is B1 more important in this case than the other B vitamins?
Thiamine, B1, is more critical in Wernicke's encephalopathy because it's essential for pyruvate dehydrogenase, which fuels the brain's energy production, and its deficiency directly causes the specific brain damage seen, unlike other B vitamins.
What about dextrose?
Good question. Let's talk about dextrose in the context of Wernicke's encephalopathy and alcohol dependence, keeping it quick and clear. Dextrose, a simple sugar, glucose, given IV, can be risky in alcoholics with suspected Wernicke's because their thiamine-deficient brains can't process glucose properly, potentially worsening brain damage or triggering acute Wernicke's symptoms like confusion or ataxia. That's why you always give thiamine IV first, e.g., 500 milligrams, before any dextrose infusion to restore the brain's ability to metabolize glucose safely. Want me to explain how this interaction works in more detail or something else?
No, that's good. Let's go to another topic of the day, which is chronic liver disease. Tell us, what can cause chronic liver disease? How is it related to alcohol use disorder? How do things like hematemesis occur? And yeah, let's start from there. Why might we have a GI bleed?
All right, let's pivot to chronic liver disease for the podcast, covering its causes, how it ties to alcohol use disorder, and why things like hematemesis and GI bleeds happen. Chronic liver disease is long-term liver damage that impairs its function, often progressing to scarring, cirrhosis. Causes include heavy alcohol use, viral hepatitis, like B or C, fatty liver disease from obesity or diabetes, autoimmune disorders, and genetic conditions like hemochromatosis. Alcohol use disorder is a major driver because consistent heavy drinking, e.g., over 30-40 units weekly for years, overwhelms the liver, causing fatty liver, then alcoholic hepatitis, and eventually cirrhosis in about 10-20% of heavy drinkers. The liver breaks down alcohol into toxic byproducts like acetaldehyde, which inflame and scar liver tissue over time. Now, hematemesis, vomiting blood, and GI bleeds are serious complications often linked to cirrhosis from alcohol. Cirrhosis increases pressure in the portal vein, portal hypertension, causing swollen veins, varices, in the esophagus or stomach. These varices can rupture, leading to massive GI bleeding, which shows up as hematemesis or black, tarry stools. About 30% of cirrhotics develop variceal bleeds, and alcohol worsens this by thinning blood and impairing clotting. Other GI bleed causes in these patients include ulcers or gastritis, often from alcohol's direct irritation of the stomach lining. Want me to dive deeper into managing these bleeds or another aspect of chronic liver disease?
Well, so hematemesis is GI bleed or no? You say good stuff, but you talk too much sometimes, and I get confused.
My bad for overloading you. I'll keep it tight. Hematemesis is vomiting blood and is often a sign of a GI bleed, like from ruptured esophageal varices and cirrhosis caused by alcohol use disorder. It happens when high pressure in the liver's portal vein, due to scarring, makes these veins burst. Want me to clarify anything specific about this or move to another part?
Why they burst? Why scarring in the first place?
All right, let's zero in on why esophageal varices burst and why scarring happens in chronic liver disease, keeping it short and clear. Scarring or cirrhosis occurs because heavy alcohol use, like 30 plus units weekly for years, produces toxic byproducts that inflame and damage liver cells, leading to scar tissue buildup that replaces healthy liver tissue. This scarring blocks blood flow through the liver, raising pressure in the portal vein, portal hypertension, which forces blood into nearby veins like those in the esophagus, forming varices. These varices are fragile and can burst under high pressure, causing severe bleeding like hematemesis. Want me to explain how to prevent or treat these bleeds?
I don't really get it.
Hassan,
I don't
Yeah,
really
do-
get this hematemesis. So we have these things that bleed in the GI, but why do they bleed? Why do we have the cirrhosis?
all right. Let's make hematemesis and its connection to cirrhosis super clear, focusing on why the bleeding happens and why cirrhosis develops. Cirrhosis is scarring of the liver caused by long-term damage.
Okay. Tell me more, dude.
All right, my bad. I think you threw in some Arabic there, but since
No,
you're
I
saying
didn't,
tell
I
me more,
didn't.
dude, I'll pick up where we left off on why esophageal varices burst and liver scarring happens in chronic liver disease. Diving a bit deeper while keeping it concise for the podcast. We were talking about how heavy drinking and alcohol use disorder causes cirrhosis, scarring from repeated liver damage by alcohol's toxic byproducts, like acetaldehyde, which kills liver cells over years. Think 30 to 40 units a week, long term. This scar tissue messes up the liver's blood flow, spiking pressure in the portal vein.
But why do we have it in the first place?
All right, let's get to the root of why we get liver scarring, cirrhosis, in the first place, especially tied to alcohol use disorder. Keeping it sharp and clear. Chronic heavy drinking floods the liver with alcohol, which it metabolizes into toxic acetaldehyde, causing inflammation and killing liver cells. Over years, like 30 plus units weekly, the liver keeps trying to repair itself, but this repeated damage leads to scar tissue buildup, replacing healthy liver tissue and starting cirrhosis. Want me to explain how this progresses to complications like varices or something else?
I want to ask about dextrose again, to be honest. I still don't understand how the scarring occurs in the first place. And yeah. I also want to ask about Korsakov's amnesic syndrome. 2-3 sentences total. Don't go crazy.
Heavy alcohol use causes liver scarring, cirrhosis, by producing toxic acetaldehyde, which inflames and destroys liver cells, triggering scar tissue formation over years. Dextrose worsens Wernicke's encephalopathy in thiamine-deficient alcoholics by overloading the brain with glucose it can't process, accelerating brain damage. Korsakoff's amnesic syndrome, often following untreated Wernicke's, is a chronic memory disorder from thiamine deficiency, causing severe short-term memory loss and confabulation.
I don't get this Korsakoff's amnesic syndrome. What is this?
All right, let's clarify Korsakoff's amnesic syndrome, keeping it simple and clear for the podcast. Korsakoff syndrome is a chronic brain disorder, usually following untreated Wernicke's encephalopathy, caused by severe thiamine, vitamin B1 deficiency in heavy alcoholics. It leads to profound short-term memory loss, where patients can't form new memories, often confabulate, make up stories to fill gaps, and may struggle with coordination despite seeming alert. Want me to explain how it develops from Wernicke's or its treatment?
Yes.
All right, let's dive into how Korsakoff's amnesic syndrome develops from Wernicke's encephalopathy, keeping it clear and concise for the podcast. Wernicke's encephalopathy, caused by thiamine, vitamin B1 deficiency in heavy drinkers, damages brain areas like the mammillary bodies and thalamus due to energy failure from impaired glucose metabolism. If untreated, this acute damage progresses to Korsakoff syndrome in about 80% of cases, causing permanent brain injury that leads to severe short-term memory loss, confabulation, and sometimes coordination issues, as thiamine-starved neurons die off. Treatment involves urgent IV thiamine to halt Wernicke's progression, but Korsakoff's memory deficits are often irreversible, though rehab and support can help manage symptoms. Want me to focus on specific brain changes or treatment strategies?
Yes, please.
All right, let's zoom in on the specific brain changes in Korsakoff's amnesic syndrome and the treatment strategies, keeping it clear for the podcast. In Korsakoff's syndrome, thiamine deficiency from chronic alcohol use causes neuron death in key brain areas. The mammillary bodies shrink, the thalamus, especially the medial dorsal nucleus, loses cells, and frontal lobe connections weaken, leading to severe short-term memory loss, confabulation, and impaired learning. Treatment starts with immediate IV thiamine, e.g. 500 milligrams 3 times daily for 3 to 5 days, to stop Wernicke's progression, followed by oral thiamine and nutritional support. But Korsakoff's memory damage is often permanent, so rehab, memory aids, and counseling are used to manage symptoms and improve quality of life. Want me to dig into one brain region's role or a specific rehab approach?
I want to ask you about confabulation. What is this, and how does it relate with Korsakoff's amnesic syndrome?
All right, let's dive into confabulation and how it ties to Korsakoff's amnesic syndrome, keeping it straightforward for the podcast. Confabulation is when someone with Korsakoff syndrome unintentionally makes up stories or details to fill memory gaps, believing them to be true, due to severe short-term memory loss from thiamine deficiency damaging the brain's frontal lobes and thalamus. In Korsakoff's, this happens because patients can't form new memories, so their brain fabricates plausible but false narratives, like claiming they just met someone when they haven't, as a way to cope with the memory void. Want me to explain how this differs from lying or dive deeper into the brain damage causing it?
Very interesting.
Glad you're finding it interesting. Since we were just talking about confabulation in Korsakoff syndrome, where patients make up stories to fill memory gaps due to brain damage, do you want to explore more about how this impacts daily life? Or maybe shift to another angle, like other symptoms or treatment challenges?
I want to ask about prognosis in Korsakoff's, and yeah. What other things can alcohol cause that we haven't talked about?
All right, let's cover the prognosis for Korsakoff's amnesic syndrome, and then touch on other alcohol-related conditions we haven't discussed yet, keeping it clear and concise for the podcast. For Korsakoff syndrome, the prognosis is often poor because the memory deficits caused by permanent brain damage from thiamine deficiency are usually irreversible. About 75% of patients need long-term care due to severe short-term memory loss and confabulation, though early IV thiamine can halt progression if caught in the Wernicke's stage. Beyond what we've covered, like Wernicke's, cirrhosis, and GI bleeds, alcohol can cause pancreatitis, painful inflammation of the pancreas from enzyme buildup, alcoholic cardiomyopathy, weakened heart muscle leading to heart failure, peripheral neuropathy, nerve damage causing numbness or tingling in limbs, and increased risk of cancers like mouth, throat, and liver cancer. It also raises the risk of mental health issues like depression and anxiety, often worsening social and cognitive decline. Want me to zoom in on one of these conditions or the prognosis details, like care options for Korsakoff's?
Yeah, let's do it. And then I'm going to ask you about Spider Navy.
All right, let's dive deeper into the prognosis for Korsakoff's amnesic syndrome and care options. Then we'll get to this spider lady you mentioned, keeping it clear and podcast friendly. For Korsakoff syndrome, the prognosis is tough. About 75% of patients face permanent memory deficits due to irreversible brain damage in areas like the thalamus and mammillary bodies, leading to severe short-term memory loss and confabulation. Early IV thiamine, 500 milligrams 3 times daily during the Wernicke stage, can prevent progression, but once Korsakoff sets in, only about 25% make a good recovery with partial memory improvement. Most need long-term support, like assisted living, memory aids, or rehab programs to manage daily life. Beyond what we've discussed, alcohol-related conditions also include fetal alcohol syndrome, developmental issues in babies from maternal drinking, alcoholic myopathy, muscle weakness, and social issues like job loss or family breakdown, which compound the health toll. Now, about this spider lady. I'm guessing you might be referring to a case...
Spider Navy, dude, in regarding chronic liver disease.
My bad. I'm guessing you're referring to spider angiomas or something similar when you say spider lady.
Naevi.
Got it. Thanks for clarifying. You're talking about spider navy or spider angiomas, not spider lady, in relation to chronic liver disease. Let's dive into that, tying it back to your earlier question about prognosis for Korsakoff's and other alcohol-related issues. Keeping it concise for the podcast. Spider navy are small, spider-like blood vessels visible under the skin with a central red dot, a dilated arteriole, and radiating capillaries, often seen in chronic liver disease, especially cirrhosis caused by heavy alcohol use. They form because liver damage disrupts estrogen metabolism, leading to high estrogen levels that dilate blood vessels. They're a key sign of advanced liver disease, appearing in about 33% of cirrhotics, often on the face, chest, or arms. In alcohol use disorder, spider navy signals severe liver scarring, which ties to complications like portal hypertension and GI bleeds, like hematemesis from varices, and they're linked to worse prognosis, including higher mortality risk in alcoholic liver disease. Tying this to Korsakoff's prognosis from your earlier question, both conditions show alcohol's devastating long-term effects. Korsakoff's leaves most patients, 75%, with permanent memory issues needing lifelong care, while spider navy and cirrhosis indicate advanced liver failure, where 50% of patients may die within 1 to 2 years without transplant or sobriety. Other alcohol-related issues
Wait. So, what What exactly is Spider Navy? And I hope you fucking can understand what Navy means now. In a sentence or two. Don't talk too much. Just explain to us.
Spider Navy are small, spider-like skin lesions with a central red dot and radiating capillaries, caused by high estrogen from liver damage and chronic alcohol-related cirrhosis. They signal advanced liver disease and often appear on the face or chest.
And why do they appear?
Spider Navy appear in chronic liver disease because the damaged liver, often from heavy alcohol use, can't properly break down estrogen, causing excess estrogen to dilate blood vessels under the skin, forming these spider-like lesions. They show up most in cirrhosis as a sign of severe liver dysfunction. Want me to explain how they're managed, or
No,
something
I don't
else?
understand how they appear. Tell me again.
Spider Navy form when chronic liver damage, like cirrhosis from heavy drinking, impairs the liver's ability to metabolize estrogen, leading to elevated estrogen levels that dilate small blood vessels under the skin, creating red, spider-like patterns. They typically appear on the face, neck, or chest as a visible sign of advanced liver dysfunction. Want me to dive into anything specific about them, like treatment or related complications?
I don't understand why they appear.
Alright, let's break it down super simply to clear up why Spider Navy appear. Heavy alcohol use scars the liver, cirrhosis, making it unable to break down estrogen properly. So estrogen builds up and causes tiny blood vessels under the skin to widen, forming red, spider-like spots, especially on the face or chest. Want me to explain any part of this process?
Yes,
Like,
why do they appear because of liver? I don't get the connection.
Okay, let's make the connection between the liver and Spider Navy crystal clear, step by step, for the podcast. The liver normally breaks down excess estrogen, a hormone that affects blood vessels. In chronic liver disease, like cirrhosis from heavy alcohol use, the liver is scarred and can't do this job well, so estrogen levels rise. High estrogen makes small blood vessels under the skin, capillaries, dilate, forming Spider Navy, red, spider-like spots with a central dot and radiating lines, often on the face or chest. It's a visible sign the liver's failing to regulate hormones. Want me to clarify any part or move to something else?
I still don't understand the reason that we have this because of a problem with the liver. I don't understand the link.
No worries. Let's nail down the link between liver damage and Spider Navy in the simplest way possible. When you drink heavily for years, alcohol scars your liver, cirrhosis, and a scarred liver can't filter estrogen properly, letting too much estrogen build up in your blood. That excess estrogen makes tiny skin blood vessels grow and spread out, creating Spider Navy, those red, spider-like spots. Want me to explain one specific part? Like how estrogen affects the vessels, or something else?
Can you explain it again? I'm sorry, guys. I just can't get it in my mind.
No problem at all. Let's try another angle to make the Spider Navy and liver connection super clear for you and the podcast listeners. Imagine your liver as a filter that normally cleans out extra estrogen, a hormone. When heavy drinking damages the liver with scars, cirrhosis, it stops filtering well. So estrogen piles up in your body, causing small blood vessels in your skin to swell and form red, spider-like patterns called Spider Navy.
Alright, fair enough. And so we talked about the GI bleed and the cirrhosis. Can you explain us what cirrhosis is again?
All right, let's revisit cirrhosis in a clear, concise way for the podcast, tying it to our earlier
Get on with
chats
it. Don't do introductions, I said. 1-2 sentences I want only. In general, I only want 1-2 sentences unless I specify otherwise, so please remember this.
Cirrhosis is severe liver scarring from chronic alcohol damage, replacing healthy tissue with scar tissue. It causes complications like GI bleeds from portal hypertension and varices.
Interesting. Okay, let's continue our discussion. So, let's talk a bit more about cirrhosis, and if you could explain how it connects to like ascites, coagulopathy, jaundice.
Cirrhosis, caused by chronic alcohol damage scarring the liver, leads to ascites, coagulopathy, and jaundice because the scarred liver can't function properly. Ascites is fluid buildup in the abdomen due to portal hypertension. Coagulopathy is poor blood clotting from reduced liver-made clotting factors. And jaundice is yellowing skin from the liver failing to process bilirubin. Want me to dive deeper into one of these complications?
Yeah, I don't understand. Coagulopathy basically is what?
Coagulopathy in cirrhosis means the liver, scarred from chronic alcohol use, can't produce enough clotting proteins, like factors 2, 5.
I see.
So, we were just talking about how coagulopathy in cirrhosis happens because the scarred liver can't make enough clotting proteins, causing bleeding issues. Want me to explain more about how this ties to other cirrhosis
I
complications?
want to understand how inflammation causes fibrosis, which causes cirrhosis.
Chronic alcohol use triggers liver inflammation by producing toxic byproducts, like acetaldehyde, which damage liver cells and cause ongoing immune responses that deposit scar tissue, fibrosis. Over years, this fibrosis builds up, replacing healthy liver tissue with rigid scar tissue, leading to cirrhosis and impairing liver function. Want me to clarify any part of this
Explain
process?
this again, sorry, in a sentence or so.
Heavy drinking causes liver inflammation via toxic alcohol byproducts, leading to scar tissue buildup, fibrosis, that, over time, replaces healthy liver tissue, resulting in cirrhosis. Want me to break down a specific step?
Okay. So, what is the difference between fibrosis and cirrhosis?
Fibrosis is the early stage of liver scarring, where excess scar tissue forms due to chronic alcohol-induced inflammation, but the liver can still function. Cirrhosis is the advanced stage, where extensive fibrosis severely disrupts liver structure and function, causing complications like portal hypertension.
Can you explain to me how the liver connects to the reticuloendothelial system?
The liver connects to the reticuloendothelial system because it houses Kupffer cells, specialized macrophages that filter pathogens, toxins, and debris from blood, supporting the system's immune and cleanup roles. In cirrhosis from alcohol, these cells become overactive, contributing to inflammation and worsening liver damage. Want me to dive deeper into this immune role or something else?
Explain this a bit more, to be honest. Explain how a normal liver will be connected to the reticuloendothelial system, bile formation.
In a normal liver, the reticuloendothelial system is linked through Kupffer cells, macrophages that clear bacteria, toxins, and old blood cells from the bloodstream, supporting immune defense. The liver also produces bile, formed in hepatocytes from cholesterol and bilirubin, which is secreted into the bile ducts to aid fat digestion and remove waste, independent of the reticuloendothelial system. Want me to clarify how these processes change in cirrhosis?
Yeah, for sure. Explain also why we might have portal hypertension, hypersplenism, varices, I don't know what that is. Yeah. Hepatic encephalopathy.
In cirrhosis, scarring disrupts normal liver function, impacting the reticuloendothelial system, bile formation, and causing portal hypertension, hypersplenism, varices, and hepatic encephalopathy. The scarred liver's Kupffer cells overreact, worsening inflammation. Bile production drops, leading to jaundice. Portal hypertension arises from blocked blood flow, causing varices, swollen veins that can bleed. Hypersplenism, overactive spleen trapping blood cells, and hepatic encopathy, brain dysfunction from toxin buildup. Want me to focus on one of these complications?
Yes, these varices, I don't understand what it is. I don't understand hypertension, how it will occur, and hypersplenism either, to be honest. And hepatic encephalopathy and jaundice. I don't understand anyone how they will occur.
All right, let's clearly explain varices, portal hypertension, hypersplenism, hepatic encopathy, and jaundice in cirrhosis, keeping it simple and focused. In cirrhosis from heavy alcohol use, scarred liver tissue blocks blood flow, causing portal hypertension, high pressure in the portal vein, which leads to varices, swollen, fragile veins in the esophagus or stomach that can burst and bleed. Hypersplenism, an overactive spleen trapping blood cells, lowering counts. Hepatic encopathy, confusion from toxins like ammonia building up due to liver failure. And jaundice, yellow skin from unprocessed bilirubin. Want me to dive deeper into one of these or clarify a specific mechanism?
It's okay. So tell us about some causes of cirrhosis, like metabolic dysfunction, and how it's associated with this steatotic liver disease, and explain a bit this steatotic liver disease. Explain us hemochromatosis, Wilson disease, viral hepatitis C, B.
Cirrhosis can be caused by metabolic dysfunction-associated steatotic liver disease, MASLD, hemochromatosis, Wilson disease, and viral hepatitis B and C, alongside alcohol. MASLD, driven by obesity and diabetes, causes fat buildup in the liver, steatosis, leading to inflammation and fibrosis that can progress to cirrhosis. Hemochromatosis, excess iron storage. Wilson disease, copper accumulation, and chronic hepatitis B or C, viral infections, similarly inflame and scar the liver over time. Want me to detail one of these causes or their progression?
It's okay. Explain us compensated and decompensated cirrhosis, and explain us how LFTs will be in each case, and how each will look.
Compensated cirrhosis is when the scarred liver still functions adequately, often with normal or slightly abnormal liver function tests, LFTs, like mildly elevated ALT, AST, or low albumin, and patients may have no symptoms. Decompensated cirrhosis is when the liver fails, showing markedly abnormal LFTs. High bilirubin, very low albumin, prolonged INR, and symptoms like ascites, jaundice, variceal bleeding, or hepatic encopathy. Want me to explain how to manage these stages?
I don't understand the differences still, to be honest.
Compensated cirrhosis means the scarred liver still works enough to handle its jobs, with few or no symptoms and LFTs that are normal or only slightly off, e.g., mildly high, ALT, AST. Decompensated cirrhosis is when the liver can't keep up, causing severe symptoms like fluid buildup, ascites, yellowing, jaundice, or confusion, encopathy, with LFTs showing high bilirubin, low albumin, and prolonged INR. Want me to focus on one aspect?
Dude,
like
you're telling me that which symptom and sign goes where, but I don't understand why.
All right, let's clarify why certain symptoms and signs show up in compensated versus decompensated cirrhosis, breaking it down simply. In compensated cirrhosis, The liver is scarred but still manages its core functions, like detoxifying, making proteins, and processing bilirubin. So you might see no symptoms or just mild ones like fatigue. And LFTs are near normal because the liver compensates. In decompensated cirrhosis, the liver scarring is so severe it fails at these tasks, leading to symptoms like ascites from portal hypertension, jaundice from unprocessed bilirubin, bleeding varices from high portal vein pressure, and encopathy from toxin buildup, with LFTs showing high bilirubin, low albumin, and prolonged INR due to this dysfunction. Want me to zoom in on one symptom's cause or something else?
Yeah, no, that's good. That's a bit better. So, what are LFTs?
LFTs, or liver function tests, are blood tests measuring levels of enzymes ALT, AST, bilirubin, albumin, and clotting time, INR, to assess how well the liver is working. In cirrhosis, compensated cases show near normal LFTs, while decompensated cases have high bilirubin, low albumin, and prolonged INR, reflecting severe liver failure. Want me to explain one specific test or move to another topic?
I see. Okay, so we have a central vein, and we have hepatic portal vein, hepatic artery, bile ducts. I'm trying to understand all of these. So let me find on Wikipedia a liver lobule.
All right. It sounds like you're trying to understand the liver's anatomy, specifically the central vein, hepatic portal vein, hepatic artery, bile ducts, and how they relate to the liver lobule, possibly while checking Wikipedia for a visual. Let me clarify this simply to help you picture it. A liver lobule is the functional unit of the liver, a hexagonal structure with a central vein in the middle, where blood exits. At the lobule's corners, you have the portal triad, the hepatic portal vein, bringing nutrient-rich blood from the gut, the hepatic artery, supplying oxygen-rich blood, and the bile duct, carrying bile, made by liver cells, to the gallbladder and gut for digestion. In cirrhosis, scarring disrupts this setup, blocking blood flow through the portal vein and causing complications like portal hypertension. Want me to explain how these structures work together or focus on their role in cirrhosis?
Makes a lot of sense. I see. So they're like the nephron, like the basic unit, but of the liver. Okay.
Exactly, you nailed it. The liver lobule is like the nephron of the kidney, the basic functional unit of the liver, with the central vein, hepatic portal vein, hepatic artery, and bile ducts working together to process blood and produce bile.
So we have portal vein, hepatic artery. What is in portal vein, hepatic artery, and bile duct?
The hepatic portal vein carries nutrient-rich, low-oxygen blood from the gut to the liver for processing. The hepatic artery delivers oxygen-rich blood to nourish liver cells. And the bile duct collects bile, made by the liver to digest fats, draining it to the gallbladder and intestines. In the liver lobule, these structures form the portal triad at the corners, supporting the liver's metabolic and digestive roles. Want me to explain their role in cirrhosis or another aspect?
Sure. And I also just wonder, okay, so the three structures in the portal triad are?
The portal triad in the liver lobule consists of the hepatic portal vein, carrying nutrient-rich blood from the gut, the hepatic artery, supplying oxygen-rich blood, and the bile duct, draining bile for fat digestion. In cirrhosis, scarring disrupts blood flow.
So portal vein, hepatic artery, and bile duct.
Yep, that's right. The portal triad in the liver lobule includes the hepatic portal vein, bringing nutrient-rich blood from the gut, the hepatic artery, providing oxygen-rich blood, and the bile duct, carrying bile for digestion. Want me to explain how these are affected in cirrhosis, or dive into another part of their function?
It's good, yes. Explain how they're connected to cirrhosis. Also explain to me hepatocytes, the sinusoids, interlobular veins.
In cirrhosis, scarring disrupts the liver lobules portal triad, hepatic portal vein, hepatic artery, bile duct, blocking portal vein blood flow, causing portal hypertension, and impairing bile drainage, leading to jaundice. Hepatocytes, liver cells, are damaged by alcohol's toxic byproducts, reducing function and forming scar tissue. Sinusoids, tiny blood channels between hepatocytes, get compressed, worsening blood flow. And interlobule veins, like the central vein, face increased pressure, contributing to complications like varices. Want me to focus on one of these changes?
Explain all of them one more time, please.
Cirrhosis scars the liver, blocking the hepatic portal veins' nutrient-rich blood flow, causing portal hypertension, while the hepatic arteries' oxygen supply and bile ducts' bile drainage are disrupted, leading to jaundice. Hepatocytes, the liver's working cells, die from alcohol's toxins, forming scar tissue. Sinusoids.
Explain me their definition, though, in general, what they usually do. Explain to me how the structure relates to the function, too.
The hepatic portal vein carries nutrient-rich blood from the gut to hepatocytes for processing. The hepatic artery supplies oxygen for liver cell function, and the bile duct drains bile, produced by hepatocytes for fat digestion. Together in the portal triad, they support the lobules' role in metabolism and detoxification. Hepatocytes process nutrients and toxins. Sinusoids allow blood exchange with hepatocytes, and interlobular, central veins collect processed blood, but in cirrhosis, scarring disrupts these structures, impairing blood flow and function. Want me to detail one part further?
Yeah, explain to me how the names relate to the function, the names of them.
The hepatic portal vein, hepatic meaning liver, portal meaning gateway, carries gut-derived blood to the liver for processing. The hepatic artery, artery for oxygen-rich blood, delivers oxygen to hepatocytes. And the bile duct, duct for transport, channels bile for digestion. Hepatocytes, hepato for liver, site for cell, metabolize nutrients and toxins. Sinusoids, sinus for channel, facilitate blood hepatocyte exchange. And interlobular, veins, interlobular, between lobules, drain processed blood, all named to reflect their roles in liver function. Want me to explore how cirrhosis impacts these roles?
I don't understand. I mean, I understand what they do. I just don't know how to remember the names of each. I guess there's something practical I need to do to kind of naturally figure it out.
To remember the names of the liver lobule structures, link them to their jobs. Hepatic portal vein, portal like a gate, brings gut nutrients. Hepatic artery, artery for oxygen, feeds the liver oxygen. And bile duct, duct like a pipe, carries bile for digestion. Hepatocytes, hepato means liver, are the liver's workhorse cells. Sinusoids, sinus-like channels, let blood mingle with those cells. And interlobular veins, between lobules, drain the blood out. A practical trick is to visualize the portal triad as a delivery team: nutrients, oxygen, bile pipe. And the others as the factory: hepatocytes, sinusoids, exit veins, Sketch a lobule or use acronyms like HAPB, hepatic artery, portal vein, bile duct. Want me to suggest more memory aids?
It's
Or
good.
move on?
Okay, and we have the inferior vena cava, and then that will branch off the inferior mesenteric vein, or something else. The renal veins, maybe. Tell me.
The inferior vena cava, IVC, is a major vein that carries deoxygenated blood from the lower body to the heart, receiving blood from the hepatic veins, draining the liver, renal veins from the kidneys, and inferior mesenteric vein via the portal vein system, among others. In the liver, the IVC collects blood from the central interlobular veins of lobules via hepatic veins, not directly from the inferior mesenteric vein, which feeds into the portal vein for liver processing first.
If you talk slightly faster. Okay, so the inferior vena cava gets we have a branch of the left and right renal vein.
Yep, the inferior vena cava, IVC, collects blood from the left and right renal veins, which drain deoxygenated blood from the kidneys, along with hepatic veins from the liver and others, carrying it to the heart. The inferior mesenteric vein, though, feeds into the portal vein system for liver processing, not directly into the IVC.
What is this portal system? Explain us more.
The portal system, specifically the hepatic portal system, is a network of veins that carries nutrient-rich, low-oxygen blood from the digestive organs, like the stomach, intestines, and spleen, via the portal vein directly to the liver for processing before it enters the general circulation. In the liver, this blood flows through sinusoids, where hepatocytes detoxify, metabolize nutrients, and regulate substances. Then exits via hepatic veins to the inferior vena cava. In cirrhosis, scarring blocks this flow, causing portal hypertension.
And
Want me to detail?
and why is it ideal? And the superior mesenteric vein and inferior mesenteric vein are part of this portal system and not part of the inferior vena cava. Same with the splenic vein.
The superior mesenteric vein, inferior mesenteric vein, and splenic vein are part of the hepatic portal system because they carry nutrient-rich blood from the intestines and spleen to the liver for processing, detoxification, and metabolism before it reaches the systemic circulation. Unlike the inferior vena cava, which collects processed, deoxygenated blood for the heart, the portal system ensures the liver first filters and regulates nutrients and toxins, optimizing metabolism and protecting the body. Want me to explain how cirrhosis disrupts this system?
It's good. And what is Mr. PB?
Mr. PB likely refers to Mr. Peanut Butter.
No,
a chi-
dude, MRPB.
My bad. Thanks for clarifying. You're asking about MRPB, which seems to be a miscommunication or typo since it doesn't directly match any standard medical or alcohol-related term in our discussion. But I'm guessing you might mean something like MRP, Material Requirements Planning.
Yeah, my bad. Sorry, I got confused. Yes, my bad. I'm just stupid. Okay, let's talk about a bit more about portal hypertension and how it connects to splenomegaly.
No worries at all. Let's dive into portal hypertension and its connection to splenomegaly, keeping it clear and concise. Portal hypertension, caused by cirrhosis scarring blocking blood flow through the hepatic portal vein, increases pressure in the portal system.
Okay.
All right. Since we were just trying to sort out MRPB, and it might not be a clear term, let's
No,
keep
it's fine.
moving.
Okay, and what about OGD? What is this? And explain to me also varices and how it links to portal hypertension.
OGD, or osophagogastroduodenoscopy, is a procedure using a camera to examine the esophagus, stomach, and duodenum, often used to detect varices and cirrhosis. Varices are swollen veins in the esophagus or stomach caused by portal hypertension, where liver scarring blocks portal vein blood flow, forcing blood into these fragile veins, which can rupture and cause severe bleeding. Want me to detail OGD's role in diagnosing varices or another aspect?
Yeah, tell me again, because I don't understand these varices, to be honest.
Varices are abnormally swollen veins in the esophagus or stomach that form when cirrhosis scars the liver, causing portal hypertension by blocking blood
So
flow
it doesn't
through
have to do with like coronary artery disease or something. Or, sorry, not coronary, in general, like artery disease.
No, varices are not related to artery disease like coronary artery disease. They're swollen veins, not arteries, in the esophagus or stomach caused by portal hypertension from liver cirrhosis, where scarred liver tissue blocks portal vein blood flow. Artery disease involves plaque buildup in arteries, while varices stem from high venous pressure due to liver damage, often from alcohol, leading to potential bleeding. Want me to clarify how varices are managed or another point?
Yes, please.
Varices, caused by portal hypertension from cirrhosis, are managed with OGD, osophagogastroduodenoscopy, to detect them, beta blockers like propranolol to lower portal pressure, and banding or sclerotherapy to prevent or treat bleeding. If bleeding occurs, urgent OGD with banding or medications like octreotide can stop it. And in severe cases, a TIPS procedure, shunting blood flow, or liver transplant may be needed. Want me to focus on one treatment or
I
another
want to ask you
aspect of
about
varices?
what about when do we use IV terlipressin?
IV terlipressin is used in acute variceal bleeding from portal hypertension and cirrhosis to constrict blood vessels, reduce portal vein pressure, and control bleeding, typically alongside OGD and banding. It's given when a patient presents with active bleeding, e.g., hematemesis, and continued for 2-5 days to prevent rebleeding, but not for prevention without active hemorrhage. Want me to explain its mechanism or another treatment?
That makes sense. And what about ultrasounds? When will we use ultrasounds in portal hypertension?
Ultrasounds, especially Doppler ultrasounds, are used in portal hypertension to assess liver structure, detect cirrhosis, measure portal vein blood flow, and identify complications like varices or ascites. They're typically done for initial diagnosis, routine monitoring of cirrhosis patients, or when symptoms like abdominal swelling or bleeding suggest portal hypertension. Want me to detail what ultrasounds show or another aspect?
Yeah, please do.
Doppler ultrasounds in portal hypertension show liver scarring, cirrhosis, portal vein size and flow direction, slow or reversed in severe cases, and signs of complications like ascites, splenomegaly, or varices, helping diagnose and monitor disease progression. They're non-invasive, used routinely every 6-12 months in cirrhosis patients, or urgently if symptoms like abdominal swelling or GI bleeding arise, guiding treatment decisions. Want me to explain how these findings lead to specific treatments or something else?
Is there something like if you die for someone, you means you love them, like a mom dying for her kid? Is there anything even more than a self? Like, can you think of a bigger like sacrifice you would do someone for someone than that. I was thinking maybe one is to live for them in a specific way. For instance, to try your best for your whole life to be a good man. For instance, is that even harder? Well, I don't want to put them like let's rank how we can be good people. I'm just asking like, what do you think? Like, what's the biggest sacrifice in any way you can do for someone, or investment, or whatever you want to call it?
That's a deep question, shifting gears to something profoundly human: love, sacrifice, and what it means to give for others. The idea of dying for someone, like a mom for her kid, is often seen as the ultimate sacrifice because it's giving up your entire existence, your life, for their survival or well-being. But you're onto something interesting with living for someone in a specific way, like striving to be a good man your whole life. That's a different kind of sacrifice, one that demands ongoing effort, self-discipline, and purpose over decades, which can be incredibly powerful. I'd say the biggest sacrifice or investment you can make for someone depends on context, but living for them with intention, like dedicating your life to embody values they cherish or to support their dreams, might edge out even death in some ways. Dying is a single, monumental act, final and selfless, but living for someone, shaping every choice to honor or uplift them, say, raising a child with unwavering care or living ethically to inspire others, requires sustained courage and constant renewal of that commitment. For example, a parent who works tirelessly to give their kid a better future, or someone who forgives a loved one's betrayal and chooses to love them daily despite pain, shows a sacrifice that's not just a moment, but a lifetime. It's less about ranking and more about what resonates. Dying for someone is instinctual, visceral. Living for them is deliberate, a marathon of love. What do you think?
Interesting.
Does that feel...
Okay, can you imagine anything even bigger than the two things I mentioned? Something specific?
Beyond dying for someone, like a mom for her child, or living intentionally for them, like striving to be a good person for their sake, an even greater sacrifice could be giving up your core identity or deepest beliefs for someone else's well-being, such as a pacifist taking up arms to protect their family, forever altering their sense of self. This specific act demands not just life or effort, but a profound internal surrender of who you are, carrying a lifelong emotional and moral cost. Want me to explore another
that's
example?
Beautiful. Yeah, give us one more.
All right, I'm glad that resonated. Let's dig deeper with another specific example of a sacrifice that might surpass dying or living intentionally for someone, aiming for that profound emotional weight. Imagine someone who abandons their life's passion or legacy, like a brilliant artist who stops creating to care for a loved one with a chronic illness, pouring every moment into their comfort.
One more. Come on, and we have to continue.
All right, one more big sacrifice. Picture someone who sacrifices their freedom, knowingly accepting imprisonment or exile to protect a loved one's secret or safety, like a sibling taking the blame for a crime to shield their family, living in confinement while their loved one thrives.
Okay, let's talk about jaundice and how it connects to bilirubin and albumin.
Jaundice and cirrhosis happens when the scarred liver can't process bilirubin, a yellow waste product from red blood cell breakdown, causing it to build up and turn skin and eyes yellow. The damaged liver also produces less albumin, a protein that regulates blood fluid balance, worsening complications like ascites, but albumin itself doesn't directly cause jaundice. Want me to dive deeper into how bilirubin buildup is managed?
Why it decreases albumin, and also how do erythrocytes, macrophages of the spleen and bone marrow, heme, how do these connect to bilirubin? And explain us also how the gallbladder, the bile, the intestines connect to bilirubin, the urobilinogen and the urobilin and the stercobilin.
cirrhosis, albumin decreases because scarred hypercocytes can't produce enough of this protein, which normally maintains blood fluid balance, leading to complications like ascites. Erythrocytes, red blood cells, are broken down by spleen and bone marrow macrophages, releasing heme that's converted to bilirubin in the liver. In cirrhosis, the liver's failure to process bilirubin causes jaundice. The gallbladder stores bile, which carries conjugated bilirubin from the liver to the intestines, where bacteria convert it to urobilinogen, then urobilin in urine, and stercobilin in feces. But liver damage disrupts this, increasing blood bilirubin. Want me to focus on one part, like treatment or specific pathways?
I want to ask why heme becomes bilirubin, actually.
Heme, from broken down red blood cells, becomes bilirubin when spleen and bone marrow macrophages degrade hemoglobin, releasing heme, which is then converted to biliverdin, and finally bilirubin by enzymes like heme oxygenase. In cirrhosis, the liver struggles to process this bilirubin, leading to jaundice as it accumulates in the blood.
And why is bilirubin conjugated? And also, what is urobilinogen, stercobilin, and urobilin?
Bilirubin is conjugated, bound to glucuronic acid in the liver to become water-soluble, allowing it to be excreted in bile to the intestines. In cirrhosis, impaired conjugation causes unconjugated bilirubin buildup, leading to jaundice. Urobilinogen is formed when intestinal bacteria break down conjugated bilirubin. Some is reabsorbed and becomes urobilin, yellow in urine, while the rest becomes stercobilin, brown in feces. Want me to clarify any part or move on?
No, it's good. So I don't understand, to be honest. What urobilin, stercobilin, and urobilinogen are.
Urobilinogen is a colorless compound formed when intestinal bacteria break down conjugated bilirubin from bile. Some urobilinogen is reabsorbed and oxidized to urobilin, giving urine its yellow color, while the rest stays in the intestines, becoming stercobilin, which makes feces brown.
And why is our urine yellow when we don't drink water? Is it because if we drink water it becomes less concentrated and is whiter? Or is it because of urobilin?
Urine is yellow mainly due to urobilin, formed from bilirubin breakdown. But when you don't drink enough water, urine becomes more concentrated, making urobilin's yellow color more intense and darker. Drinking water dilutes urobilin, lightening urine's color, so concentration plays a big role alongside
And
urobilin's
what is this? I don't understand this, to be honest. This urobilin is a breakdown of what?
Urobilin is a yellow pigment in urine formed from the breakdown of bilirubin, which comes from heme in old red blood cells. Intestinal bacteria convert bilirubin into urobilinogen, some of which is reabsorbed and oxidized into urobilin. In cirrhosis, impaired bilirubin processing can alter urobilin levels, affecting urine color.
Explain this again.
Urobilin, the yellow pigment in urine, comes from bilirubin, a byproduct of heme from broken down red blood cells, processed by the liver. Gut bacteria turn bilirubin into urobilinogen, some of which is reabsorbed and becomes urobilin, coloring urine. In cirrhosis, liver dysfunction disrupts bilirubin breakdown, potentially reducing urobilin and affecting urine color. Want me to focus on one step or another topic?
So when we have bilirubin problems, we have urobilin problems too, or no?
In cirrhosis, bilirubin problems, like buildup causing jaundice, can reduce urobilin in urine because the liver struggles to process bilirubin into conjugated bilirubin for gut bacteria to convert into urobilinogen and then urobilin, leading to paler urine. However, unconjugated bilirubin may still rise in blood, not directly affecting urobilin, but causing other symptoms. Want me to clarify this link or move on?
I want to ask about obstructive jaundice.
Obstructive jaundice occurs when a blockage, like gallstones or a tumor, prevents bile containing conjugated bilirubin from flowing from the liver to the intestines, causing bilirubin to back up into the blood, leading to yellow skin and eyes. Unlike cirrhosis-related jaundice, urobilin in urine decreases because less bilirubin reaches the gut to form urobilinogen, resulting in pale stools and dark urine from excess conjugated bilirubin. Want me to explain diagnosis or treatment for this?
I don't get it. So I don't get this obstructive jaundice.
Obstructive jaundice happens when something like a gallstone or tumor blocks the bile duct, stopping bile and conjugated bilirubin from reaching the intestines. So bilirubin builds up in the blood, causing yellow skin and eyes.
So it builds up, but where is it produced initially?
Bilirubin is initially produced in the spleen and bone marrow when macrophages break down heme from old red blood cells, forming unconjugated bilirubin, which the liver then conjugates for excretion in bile. In obstructive jaundice, a blocked bile duct prevents this conjugated bilirubin from leaving the liver, causing it to build up in the blood and turn skin yellow. Want me to clarify any step or move on?
Yeah, clarify. I don't understand it.
All right, let's simplify where bilirubin comes from and why it builds up in obstructive jaundice. Bilirubin starts in the spleen and bone marrow, where old red blood cells are broken down, releasing heme that turns into unconjugated bilirubin. The liver converts it to conjugated bilirubin for bile, but in obstructive jaundice, a blockage, like a gallstone, stops bile from flowing out, so conjugated bilirubin piles up in the blood, causing yellow skin. Want me to focus on one part, like the blockage or bilirubin's path?
It's okay. Let's talk a bit about ultrasound. And when do we use it when we have such problems? And to understand what? Can we understand about the common bile duct things, or the biliary tree, or the gallbladder? What? Pancreas, to see how it links to obstructive jaundice or something.
Ultrasound is used in suspected obstructive jaundice to visualize the common bile duct, biliary tree, gallbladder, and pancreas, detecting blockages like gallstones, tumors, or dilated ducts, causing bilirubin buildup. It shows if the gallbladder is inflamed, the bile duct is widened, indicating obstruction, or the pancreas has masses, helping pinpoint the cause of jaundice non-invasively. Want me to detail what specific findings mean, or how ultrasound guides treatment?
Tell me about ERCP.
ERCP, endoscopic retrograde cholangiopancreatography, is a procedure using an endoscope and X-rays to diagnose and treat blockages in the common bile duct or biliary tree causing obstructive jaundice, often removing gallstones or placing stents for tumors. It's typically done after ultrasound confirms a blockage, directly visualizing and relieving the obstruction to restore bile flow. Want me to explain how it's performed or its risks?
That's good. So, yeah, why not? And also tell me about what pruritus is when we're taking history of such patients.
ERCP involves passing an endoscope through the mouth to the duodenum, injecting dye into the bile ducts for X-ray imaging, and removing blockages like gallstones or placing stents, but it carries risks like pancreatitis or infection. Pruritus, or itching, in obstructive jaundice patients occurs due to bile salts building up in the skin from blocked bile flow, often noted in their history as a key symptom. Want me to dive deeper into ERCP complications or pruritus management?
Um, I want to ask you about CLD. Pulmonary erythema, leukonychia.
Chronic liver disease, CLD, can cause pulmonary edema, fluid in the lungs, due to low albumin reducing blood osmotic pressure, leading to fluid leakage, and leukonychia, white nails, from poor liver protein synthesis affecting nail beds. These signs, alongside jaundice or ascites, reflect CLD's systemic impact, often worsened by alcohol-related cirrhosis. Want me to detail one condition's mechanism or management?
I don't understand. Explain me a bit more this CLD.
Chronic liver disease, CLD, often from alcohol or hepatitis, is long-term liver damage, progressing to cirrhosis, causing low albumin, leading to pulmonary edema as fluid leaks into lungs, and leukonychia, white nails from poor protein synthesis. It disrupts liver functions like detoxification and protein production, triggering systemic issues like fluid buildup or nail changes. Want me to focus on one complication or treatment?
I don't understand why it happens.
Chronic liver disease, CLD, like alcohol-induced cirrhosis, scars the liver, impairing its ability to produce albumin, causing fluid to leak into lungs, pulmonary edema, and poor protein synthesis, leading to white nails, leukonychia. The scarring disrupts normal liver functions, triggering these systemic complications as the body struggles with fluid balance and nutrient processing. Want me to clarify a specific part or move on?
Tell me again, I don't understand.
Chronic liver disease, CLD, often from heavy alcohol use, scars the liver, reducing its production of albumin, a protein that keeps fluid in blood vessels. So low albumin causes fluid to leak into the lungs, pulmonary edema, and poor protein supply to nails causes leukonychia, white nails. This happens because the damaged liver can't perform its normal jobs of making proteins and regulating fluid balance. Want me to break down one aspect further?
It's good. What is the international normalized ratio? And let's talk a bit about liver blood tests. ALT, AST, ALP, GGT. What is all this?
The International Normalized Ratio, INR, measures blood clotting time, elevated in chronic liver disease, due to reduced clotting factor production, indicating liver dysfunction. Liver blood tests include ALT and AST, enzymes raised in liver cell damage. ALP, elevated in bile duct issues, and GGT, high in alcohol-related damage or bile flow problems, helping assess liver injury and function. Want me to detail one test's role or specific findings in cirrhosis?
Well,
All right, since we were just talking...
explain this a bit more, to be honest.
The International Normalized Ratio.
No, I got that, but what about ALT, GGT, and ALP?
ALT, alanine aminotransferase, and AST, aspartate aminotransferase, are enzymes released when liver cells are damaged, like an alcohol-induced chronic liver disease, with higher levels indicating more severe injury. ALP, alkaline phosphatase, and GGT, gamma-glutamine transferase, rise when bile ducts are blocked or damaged, often seen in cirrhosis or alcohol-related...
Why did you stop? Okay, anyway, we got the point. And when would we inject through a catheter dye to the pancreatic or biliary ducts? This is in ERCP.
Sorry for the hiccup there. Injecting contrast dye into the pancreatic or biliary ducts during ERCP, endoscopic retrograde cholangiopancreatomy, is done when ultrasound or other imaging suggests a blockage, like gallstones or tumors, causing obstructive jaundice, to visualize and treat issues in the bile or pancreatic ducts. It's typically performed after confirming dilation or abnormalities in the biliary tree or pancreas, often within 24-72 hours of symptom onset like jaundice or pain, to diagnose and relieve the obstruction. Want me to explain the ERCP process or timing considerations
I want to
further?
ask about fibroscan and transient elastography and all of that. What is this?
Fibroscan, or transient elastography, is a non-invasive ultrasound-based test that measures liver stiffness to assess fibrosis and cirrhosis, helping diagnose chronic liver disease severity. It sends vibrations through the liver, calculating stiffness scores. Higher scores indicate more scarring, often used to monitor alcohol-related liver damage or hepatitis. Want me to explain how results are interpreted or its role in treatment planning?
Why, that's so cool. Yes, please do.
Fibroscan uses transient elastography to measure liver stiffness, giving a score in kilopascals, kPa. Below 7 kPa is normal, 7-12 kPa suggests fibrosis, and above 12 kPa indicates cirrhosis, guiding decisions like starting treatment or monitoring alcohol-related liver damage. It's quick, non-invasive, and helps track disease progression or response to lifestyle changes.
And when do we do a liver biopsy?
A liver biopsy is done when fibroscan or imaging results are unclear, or to confirm the cause and severity of liver disease, like distinguishing between alcohol-related cirrhosis and other conditions, typically guided by ultrasound. It's used if non-invasive tests can't fully assess fibrosis, inflammation, or specific diagnoses like autoimmune hepatitis, but carries risks like bleeding, so it's reserved for complex cases. Want me to explain the procedure or its risks?
Tell me more about how we differentiate between viral hepatitis, autoimmune, ischemic hepatitis. Yeah.
A liver biopsy helps differentiate viral hepatitis, autoimmune hepatitis, and ischemic hepatitis by examining liver tissue for specific patterns. Viral hepatitis, B or C, shows inflammation with viral markers. Autoimmune hepatitis reveals interface hepatitis and plasma cell infiltration. And ischemic hepatitis displays central lobular necrosis from poor blood flow. It's used when blood tests like viral serology, autoimmunicores, or high AST/ALT and imaging are inconclusive, providing a definitive diagnosis to guide targeted treatment.
How do steroids, prednisolone, and azathioprine help?
In autoimmune hepatitis, prednisolone, a steroid, reduces liver inflammation by suppressing the immune system's attack on hepatocytes, rapidly lowering ALT/AST levels, while azathioprine, an immunosuppressant, maintains remission by further calming immune activity, allowing lower steroid doses to minimize side effects.
Can we have in jaundice conjugated or unconjugated bilirubin?
Jaundice can occur with either conjugated or unconjugated bilirubin buildup. Unconjugated bilirubin rises in conditions like hemolysis or liver dysfunction, e.g., early cirrhosis, because the liver can't conjugate it, while conjugated bilirubin increases in obstructive jaundice, e.g., gallstones, or advanced liver disease, when bile flow is blocked.
Okay. Can we play a game now? Remember everything we discussed today about alcohol and about chronic liver disease? Let's play a game. It's rapid fire questions. You ask me a question and the answer I will give you should be 1 or 2 words. Let's start with 10 levels. Level 1 is going to be the easiest question and we build up to the hardest question in level 10. Let's go.
Awesome. Let's dive into a rapid fire game based on our alcohol and chronic liver disease discussion. 10 levels, starting easy and building to tough. 1 or 2 word answers. Here we go. Level 1. What's the vitamin deficiency linked to Wernicke's and Patten syndrome?
Thiamine.
Nice. Level 2. What causes spider-navia and cirrhosis?
Basically, the vessels, they get really big.
I need 1 or 2 words. Try again for level 2. What causes spider-navia and
Enlarged vessels.
Close enough. Let's roll with it. Level 3.
Well, what would you say is better?
Stick to 1 or 2 words for level 3.
Tell me
Name a-
fucking level 2, you... Sorry, guys. Tell me level 2, what would be a better answer?
No worries. For level 2, a better answer for what causes spider-navia and cirrhosis would be high estrogen. Now, let's keep going. Level 3. Name a symptom of delirium tremens. 1 or 2 words.
Confusion.
Spot on. Level 4. What's the procedure to detect esophageal varices?
CLD.
Not quite. 1 or 2 words for level 4. What's the procedure to detect esophageal varices?
I don't remember.
No problem. Let's try level 4 again. Procedure to detect esophageal varices. 1 or 2 words.
I don't know. Can you tell me the answer and can you remind me what varices is? Explain me how the name relates to the structure and function too.
All right, no worries. Let's pause the rapid fire to clear this up. The answer for level 4 is OGD, osophagogastroduodenoscopy, a procedure using a camera to spot esophageal varices. Varices are swollen, fragile veins in the esophagus or stomach, named from the Latin varix, meaning twisted vein, reflecting their dilated, twisty structure due to portal hypertension from cirrhosis blocking portal vein flow, which forces blood into these veins, risking rupture and bleeding. Their function is abnormal. They're a dangerous bypass for blood that can't flow through a scarred liver. Want to jump back to the game with level
I don't
5?
understand. Explain me again. I don't understand.
Okay, let's break down varices super clearly. Varices are bulging veins in the esophagus or stomach, named from the Latin varix, twisted vein, because they look swollen and tangled. In cirrhosis, a scarred liver blocks the portal vein, causing high-pressure portal hypertension that forces blood into these veins.
So what's the difference between spider-navia and viruses?
Spider-navia are small, spider-like skin blood vessels dilated by high estrogen from liver damage and cirrhosis, appearing as red spots with radiating lines, mainly on the face or chest. Varices are large, swollen veins in the esophagus or stomach, caused by portal hypertension from a scarred liver, named for their twisted structure, and they risk severe bleeding, unlike spider-navia, which are harmless but indicate liver dysfunction.
I see. And the spider-navia, why do they look like they look?
Spider-navia look like red spots with radiating lines, resembling a spider, because high estrogen from liver damage and cirrhosis dilates a central arteriole under the skin, with tiny capillaries branching out like legs. This occurs mainly on the face or chest due to estrogen's effect on superficial blood vessels. Want me to clarify anything or
I
jump
don't
back
get
to
why
the...
they look like that though.
Spider-navia look like a red dot with radiating lines because excess estrogen from a damaged liver failing to break it down causes a central skin arteriole to widen.
Okay.
And small...
And let's go to next level.
All right, let's jump back into the rapid fire game, picking up where we left off. Level 5. What's the the non-invasive test for liver fibrosis? 1 or 2 words.
ECPR, ECRP.
Not quite. Try again for level 5.
I don't know.
No sweat. The answer for level 5 is FibroScan. It's a non-invasive ultrasound test for liver fibrosis. Ready for level 6?
Yes, sirree.
Sweet. Here's level 6. What's the term for fluid buildup in the abdomen in cirrhosis? 1 or 2 words.
Ascites?
Nailed it. Level 7. What's the brain disorder from toxin buildup in cirrhosis? 1 or 2 words.
Something with encephalopathy. Hepatic encephalopathy.
Perfect.
You do
We'll
remember that there's levels and it's supposed to get harder.
You're right. My bad for not ramping up the challenge enough. Let's make level 8 tougher to keep the rapid fire game intense. Level 8. What's the enzyme elevated in alcohol-related liver damage, often tested in LFTs? 1 or 2.
ANT.
Close, but let's get it precise for level 8.
I don't remember.
No worries. The answer for level 8 is GGT, gamma glutamyl transferase.
What were
It's
the
an-
other? What was the other two that we talked about?
You're asking about the other liver function test enzymes we discussed, alongside GGT, right? The other 2 main ones are ALT, alanine anamine transferase, and AST, aspartate anamine transferase, which rise in liver cell damage, like from alcohol, while GGT is especially high in alcohol-related issues or bile duct problems. Want to jump to level 9 or
Yes,
clarify
let's
these
do it.
enzymes?
Let's do it.
Awesome. Let's crank it up for level 9, getting tougher. What's the procedure to relieve severe portal hypertension by shunting blood flow? 1 or 2 words.
No clue.
All good. The answer for level 9 is TIPS, transjugular intrahepatic portosystemic shunt. It's a procedure to redirect blood flow in severe portal hypertension. Ready for the final level 10.
Let's do it.
Here we go. Level 10, the toughest. What's the irreversible memory disorder linked to chronic alcohol use and thiamine deficiency? 1 or 2 words.
Irreversible. Wernicke?
Close, but let's nail it for level
Tell
10.
me, tell me.
The answer for level 10 is Korsakoff's syndrome.
This Korsakoff is irreversible.
Yep, you got the idea.
Why
Korsakoff-
is it irreversible?
Korsakoff's syndrome is irreversible because chronic thiamine deficiency from heavy alcohol use causes permanent neuron death in brain areas like the
I
thalamus
see.
and mammillary bodies.
Okay, thank you so much for watching, guys. I'll see you next time.